In general, I'm going to be talking to you about stroke prevention, and I think it's really important when you think about preventing sort of diseases that can cause disability or morbidity or death and sickness. It's really important to know what the risk factors are for those diseases so that if they're modifiable, that you're making every effort or you're having discussions with your doctor about what you can do to help prevent a stroke from occurring. So stroke is the fourth leading cause of death in the United States, and about 800,000 people a year in our country develop a stroke. There are 7 million stroke survivors, and it's a leading cause of adult disability. Up to 80% of all strokes are preventable. So what exactly is a stroke? It's a lack of blood flow to the brain that causes brain damage. It can be permanent damage, it can be temporary damage, and there's a lot of different types of strokes. The three main types of strokes are, I'll go over them. The first one is called an ischemic stroke. It's a stroke where you have a narrowing of an artery, so narrowing of oxygenated blood or the blood supply to the brain. That's usually caused by some type of plaque buildup. So things like cholesterol and diabetes can affect plaque buildup in the arteries. So that narrowing of blood causes a lack of blood supply to the brain tissue, and if it becomes significant, it can cause a stroke. There's also types of strokes called embolic strokes. Those are strokes that are caused from blood clots. So if a blood clot forms somewhere in the body and it gets dislodged, probably the primary site that we look at when we're looking for sources of clot is the heart. They can go to the brain and cause a stroke because essentially they block blood flow too by clogging up the artery and restricting blood flow. The other type of stroke is a hemorrhagic stroke. That's a type of stroke where the blood vessel ruptures and you can have bleeding in the brain or around the brain. And if you have a rupture of a blood vessel, obviously blood supply to the brain is going to be diminished because the conduit's lost, and that can cause brain tissue damage as well and is another type of stroke. So the main three types to think about are ischemic, from a narrowing or plaque buildup in the arteries, embolic, from a blood clot that gets dislodged from somewhere else in the body and goes to one of the brain vessels and causes a clot, and the third type is hemorrhagic, or a bleeding type of stroke where the blood vessel actually ruptures. The other type of stroke that you might hear about is a mini stroke. The medical term for it is a transient ischemic attack. And it's called transient or mini because the symptoms last for less than 24 hours. It can be a warning sign of a future stroke, and up to 40% of patients who have a mini stroke will go on to have a big stroke in the future. It requires medical attention and follow-up, but a lot of times because the symptoms resolve in a short period of time, either patients don't identify it as a mini stroke, or they're just so thankful it went away, they just don't do anything about it and just hope that it doesn't come back. The symptoms are really similar to a stroke, and we'll go over those in a minute. And it can be associated with permanent brain tissue damage. So sometimes if someone has a mini stroke, doesn't seek medical care right away, sees their doctor a few months later and says, oh, I had this episode one day where I couldn't speak for 10 minutes. And the doctor might get an MRI of the brain. We often see damage that has occurred and is permanent in the brain from that mini stroke. So what are some stroke symptoms? Sudden and severe headache is one type of symptom, but often they can be more subtle. Some, like sudden confusion, can last for a few minutes. Trouble speaking, numbness or weakness of a leg or an arm or of the face, facial droop, sudden dizziness or trouble walking, or vision loss. It doesn't have to be complete vision loss. It can be blurred vision. It can be loss of vision in one eye. I've had patients tell me that they've only lost vision in half of one eye, so they can't see anything below a certain level. People ignore symptoms often because they don't recognize the symptoms. They may be in denial. They think nothing can be done. Some people worry about the cost of going to see the doctor, going to the hospital, or as I mentioned, they just hope that symptoms will go away. Some stroke myths, that I wanted to identify is that strokes are not preventable, that they can't be treated, and that they only strike the elderly, and that the recovery period is brief. It's actually quite opposite. Up to 80% of strokes are preventable. A stroke requires emergency treatment. If you think you're having a stroke or suspect someone else is having a stroke, really the time to act is now. Anyone can have a stroke. We see strokes in young women, young men. We see strokes even in newborn babies. Stroke recovery can last a lifetime. It can be physical rehabilitation, loss of mental capacity, really the recovery period can last a lifetime. So what are some stroke treatments? It really depends on the type of stroke and the timing and presentation of medical care. If you present right away and your stroke etiology is from a clot, sometimes we can give a clot buster through the IV that actually goes in and breaks up the clot and restores blood flow to the brain. If done in a timely fashion, studies have shown that patients have a good response, a good chance of recovering fully. Although outside of certain time period windows, that clot buster can increase the risk of bleeding in the brain. So it's very tenuous. It's a situation that they take very seriously in the ER when patients show up with a stroke. Stents are another way that some strokes can be treated. If it's coming from a narrowing of an artery, a stent can be deployed to widen the artery or restore the diameter of the artery so that blood flow can be restored. Coils and clips are used sometimes if there's been a rupture of a blood vessel to sort of seal up where the blood vessel is leaking or bleeding from. And then medical therapy. The mainstay of treatment really for strokes are medications like aspirin and other blood thinners you may have heard of like Plavix, and then also cholesterol-lowering medications and diabetes-lowering medications. So stroke recovery, what's the prognosis? 10% of stroke survivors recover almost completely. 25% recover with minor impairments, and this terminology is sort of subjective because what's minor to someone may not be minor to someone else. 40% experience moderate to severe impairments requiring special care, and 10% require care with either a skilled care or other long-term care facility, and 15% die shortly after the stroke. The types of stroke rehab vary depending on what the deficit is. Physical therapy is obviously a mainstay of rehabilitation, walking, range of movement. Occupational therapy is another one. Sometimes if people have lost the ability maybe to use their right hand and they're right-handed, it becomes very difficult to take care of oneself. So dressing, combing one's hair, brushing teeth, those are all behaviors that sometimes need to be worked on after a stroke. Speech language therapy, often communication skills, verbalizing thoughts, organizing thoughts can become a difficult problem after having a stroke. Swallowing is a big thing. In the hospital, whenever someone has a stroke, before we allow them to eat or drink anything, we do what's called a swallow study, where we start with very thin liquids and then move up to pureed foods to make sure that their swallow reflex is intact, because if it's not, they can choke and die. And then cognition, how well is the person mentally functioning? Those types of therapies are also utilized for patients to assess them and to help them after a stroke. And then recreational therapies, things like cooking and gardening, things you can sometimes get at a community center, are also very helpful in keeping patients or restoring their normal quality of life after a stroke. Lifestyle changes for survivors and caregivers, strokes have a big impact on not just the lives of patients, but also on their family members who are sometimes caregivers. Daily living skills, as I mentioned, dressing and grooming can become a major issue. Diet, nutrition, and eating difficulties are things that need to be addressed. Skin care problems. If someone specifically is unable to walk after a stroke, they're more at risk for developing ulcers, bed sores, and infections from those things, and that requires some management and care. Pain. Often patients who have a stroke, they may lose movement in a limb, but they develop what's called a neuropathy. So even though they may not be able to move the leg is very painful. And then sexual and intimacy issues are also a problem after stroke. Some other things, behavior, depression, and anger. Sometimes an individual's personality can change after a stroke, and it can be difficult for a spouse or children to sort of, accommodate to the new personality. Memory loss is a big deal, and we mentioned already communication loss. So types of recovery services. There's rehabilitation units in some hospitals. Torrance Memorial has a rehabilitation hospital. UCLA has facilities for rehab. Inpatient rehabilitation facilities, homebound therapy. So sometimes patients will go home and have a physical therapist or an occupational therapist come to the home. Long-term care facilities, sometimes outpatient therapies. You go to physical therapy or a rehab place, that's something that works. And then community-based programs like the YMCA may provide. So be stroke smart. You want to reduce your stroke risk. You want to recognize stroke symptoms. And if you think that yourself or anyone around you is having a stroke, call 911 immediately, because the long-term effects on life can be very serious. So I'm going to go over now, and I'm going to spend the bulk of the time really talking on prevention. So we've sort of defined stroke, what the consequences are, but what are the risk factors and what can you do? One of the main risk factors of developing a stroke is high cholesterol. Cholesterol is a natural substance that's made by the body. 75% of it is made by the liver, and we get 25% of it from our diet, from food. The right levels of cholesterol are really important to maintain cell membranes and make hormones. Without cholesterol, none of us would be here today. So it's not all bad. Some cholesterol is good. What are the symptoms of high cholesterol? Really none, and that's the main issue. Some risk factors for stroke are obvious. If you smoke, if you're overweight, if you've got genetic predispositions, or you've got a lot of blood clotting disorder that puts you at risk for stroke, those are obvious. Those obviously need to be addressed. But if you have high cholesterol, you may not feel anything. And that's especially troubling because the Centers for Disease Control reports that 1/3 of adults in the US have some component of elevated cholesterol. And if there's no symptoms, a lot of times it doesn't get addressed. So who should be tested, and how can you find out if you have high cholesterol? So cholesterol recommendations from the American Heart Association is that anyone over the age of 20 years old should have cholesterol levels checked every 4 to 6 years. After that, people really need to work with their healthcare providers based on what their numbers are and what their risk factors are to determine what their risk of cardiovascular disease and stroke are. People who have cardiovascular disease or at higher risk of having a stroke need to have their risk factors assessed more often. And how often really depends on which medical therapy you're on, if any, if you're doing lifestyle modifications. And so that really needs to be carved out for an individual with their physician. Cholesterol screening is done with a blood test. It's a simple blood test. The most valuable results come from fasting blood work. So if you can fast for 8 to 12 hours and then check your cholesterol levels, those are the levels we're most interested in. Diet can affect cholesterol levels significantly. So you don't want to have lunch and then have your cholesterol drawn and then be told it's high. It can be somewhat inaccurate. So the types of cholesterols we check are HDL cholesterol, which is the quote-unquote good cholesterol, the LDL cholesterol, which is the bad cholesterol, and the triglycerides, which are the fatty acids in the blood. And what do the numbers mean? When you hear someone say, my cholesterol is high, well, is that good or bad? Cholesterol screening, I think we just did that slide, sorry. The low density, when somebody says their cholesterol is high, is that good or bad? If your LDL cholesterol is high, that's bad. Because that LDL cholesterol tends to deposit in the walls of arteries and cause what we already mentioned is plaque. The optimal level of LDL cholesterol for most people is around 100 or lower. But if you have heart disease or other risk factors, you may aim for a lower number, less than 70. So good cholesterol, HDL, if you say someone has a high HDL cholesterol, that's actually a good thing because it protects your heart from having a heart attack and from having a stroke, because it basically suppresses the LDL cholesterol from building up on your arteries. It competes for those same sites, and it doesn't build plaque like the bad cholesterol does. HDL levels of 60 and higher can help reduce your risk of heart disease, and conversely, HDL levels of less than 40 and significantly lower than 40 can actually increase your risk of developing heart disease and stroke. So triglycerides are a type of fat found in the blood. Normal levels of triglycerides we try to aim for are less than 150 milligrams per deciliter and lower. Levels higher than that can raise your risk for heart disease and stroke, metabolic syndrome, which also is a risk factor for heart disease, diabetes. Obesity, diabetes, smoking, alcohol abuse, and a lack of exercise can all contribute to high triglyceride levels. I find in my practice that triglyceride levels are often a reflection of patients' lifestyles. So if somebody's not exercising, eating a lot of fatty foods, fried foods, buttery carbs, triglycerides tend to be high. And often when the patient gets their lifestyle in order, starts exercising, loses a lot of weight, or some weight, we can see a dramatic decrease in triglyceride levels. That's a little bit different than LDL and HDL cholesterol because those seem to be affected more by genetics. Some people are born with high cholesterol, even though they're running 5 miles a day and eating a low-fat diet. And no matter what they do, that number just doesn't seem to budge. So we seem to think that the triglycerides are more a reflection of lifestyle, where the LDL and the HDL are more a reflection of the genetics. And also there's obviously components associated with lifestyle. So total cholesterol is the additive amount of cholesterol in the body, and it takes into account the LDL, the HDL, and another type of bad cholesterol that we're not going to get into here, the VLDL. And it's a total cholesterol score of less than 200. You may have heard that. You want your cholesterol less than 200. That's considered optimal. It's a little confusing because say you have, sort of a moderate or a little bit elevated LDL level, but a very high HDL level. You could be over 200, and that would be acceptable. So it's not, all or nothing with the 200 number. You have to make sure you understand your numbers and you're interpreting them correctly, because for some patients, being over 200 can be okay. Certain genetic conditions I mentioned that can contribute to high blood cholesterol levels. There's familial genetic conditions that predispose patients to having high cholesterol. That's sometimes why we check cholesterol levels in patients younger than 20 years old. So what boosts your risk of having high cholesterol? Obviously, diets high in trans fats, saturated fats, and cholesterol, being overweight or obese, not exercising. Other risk factors that you can't necessarily control: aging tends to increase cholesterol. Gender, women's risk for high cholesterol increases post-menopause, significantly because the interplay between hormones and cholesterol is very strong. So as women tend to get older, their estrogen levels drop. That's what causes menopause. That estrogen drop tends to decrease the HDL level, which is the good cholesterol, and it increases the LDL cholesterol and the triglycerides. So I often see women after, 5-10 years after menopause have a spike in their cholesterol levels, and they say, well, I haven't changed anything. I've been doing everything I always have, and my cholesterol's always been controlled. And this is probably the reason why. It's the hormone shift that affects the numbers and the levels. So some cholesterol tips, some things you can do to bring your cholesterol down. Eat more fiber. Get fats from healthy sources, such as fish and nuts and vegetable oils. Limit saturated fat and avoid trans fats. Limit red meat. If you're eating chicken, make sure you're taking the skin off, or if you're eating other lean meats, trim the fat. Boil or bake foods. Avoid fried foods. Avoid processed meats. Weight loss and smoking cessation has a dramatic effect also in decreasing cholesterol levels. Exercise. So if you're trying to reduce your cholesterol level through exercise, the American Heart Association recommends 40 minutes of moderate to vigorous aerobic exercise 3 to 4 times a week to reduce cholesterol levels. That seems like a lot, and for a lot of patients' lifestyles, that's not, appropriate. Some people can't do moderate to vigorous exercise or do not have that kind of time. I try to tell my patients, if they're trying to use lifestyle modifications to reduce cholesterol, to start off by setting reachable goals. So if they're not doing exercise, start by taking a 15-minute walk in the neighborhood, and then ramp it up. Ramp up the speed and the pace, because you want to be able to be breaking a sweat if you're doing exercise. That's going to affect your cholesterol levels. And then over time, increase the time and the frequency that you're doing it. But it can seem a little overwhelming if you're not doing anything, and then all of a sudden you hear from your doctor that this is what you need to do. So try to start off slow if you're not exercising regularly, and ramp up. If you are doing stuff and to lower your cholesterol levels, and maybe not as much, kind of keep this in the back of your mind that this is a recommendation, and if you can work up to it, that's when you're really going to be optimizing your chance of seeing a change in your numbers if you're exercising. So treatments, medications, statins are usually the first choice because they also reduce the risk of your heart attack, reduce the risk of heart attack and stroke. So besides aspirin, statin medications are the only ones really that have been shown to reduce the risk of heart attack, stroke, and death. They have been on the market for a long time. We know the drug side effect profiles, and they're usually the first-line treatment. There's a lot of anecdotal evidence or suggestions out there that statins have a lot of side effects, that patients don't want to, then that's the main reason patients don't want to take them. I don't want to spend a lot of time talking about it, but at the same time, it remains still the mainstay of treatment for cholesterol lowering. Some other types of medications are selective cholesterol absorption inhibitors, so actual medications that bind the cholesterol from the gut. from your diet and help you excrete them in your stool. These medications don't lower cholesterol as effectively, so if your cholesterol is very high, it's probably not the best option. Also, long-term studies have not shown that they decrease the risk of heart attack, stroke, or death. They do lower the numbers, but they don't do that. Other things, some older medications that are still on the market that are used, especially for patients who are intolerant to statins, are fibrates and niacin and omega-3s. So we'll take questions at the end, but I'm going to go on to talking about blood pressure here and hypertension specifically, because it's another risk factor for stroke that patients should know about so that they can help reduce the risk of developing a stroke. So some of the things we're going to go over is defining blood pressure, why it matters, the difference between the top number and the low number, which pills are on the market and why we use certain ones, and how low is too low, where do you actually want your blood pressure, and if there's a difference between your blood pressure in two arms, what does that mean? So what is blood pressure? The top number is your systolic blood pressure, and the bottom number is the diastolic blood pressure. And each one of these is generated by the heartbeat. Measurements above 140/90 are considered abnormal, and blood pressure over 120/80 is considered pre-hypertension. That's surprising to a lot of patients because when I see them in the office, they'll come and say they might be on blood pressure medication or monitoring it because they're borderline. And then I'll say, how's your blood pressure? And they're like, great. It's always about 135/80s, and I feel great. And they actually don't realize they're in the pre-hypertensive category. And that's really important to point out. People think if your blood pressure is lower than 120 often that it's too low, and that's not the case. So when you go to the doctor's office, or if you're using a blood pressure measure at home or a cuff at home, how should you take it? Because blood pressure readings are just full of ways to make mistakes and get bad readings, wrong readings. And so the first thing you want to do is avoid caffeine, alcohol, and nicotine during the 30 minutes before you take your blood pressure. Sit quietly for a few minutes with your back supported and your feet on the floor so that you're very stabilized. When making the measurement, rest your arms so your elbow is at the level of your heart. I'm sure you've been at the doctor's office and your arm has been down here and they've just been pumping the cuff. Well, that's not an adequate reading. It should really be up here at the level of your heart. You should have the cuff typically wrapped over bare skin because of timing issues in the offices. I often see patients with shirts, jackets on, cuffs wrapped around them. That's not really ideal if you're trying to manage blood pressure based off the reading. Leave the deflated cuff in place and wait a minute and take a second reading if you're confused about if the reading is right. If the readings are close, average them. And if they're not close, take a third reading. And also question whether your cuff is really working. A lot of times the over-the-counter cuffs, patients have them in their cupboards for 10, 20 years. You know, maybe they used it on an elderly parent and now they're pulling it out to use on themselves. Well, these things that you get at CVS and Rite Aid sometimes aren't designed to last that long. Our cuffs in the office are calibrated on a regular basis, so we know that they're working. We're using them on hundreds of patients a day. But if you're using one at home and you're getting numbers that you think are too low, too high, or just not consistent with what you're seeing when you're at the doctor's office, consider replacing it. If you feel like the blood pressure's, not right, check it in the other arm and see. They should be, usually in line with each other. We tolerate usually plus or minus a difference of 10 millimeters of mercury in the numbers between the two arms to consider it an adequate reading. So why does blood pressure matter? Sustained blood pressure increases the risk of stroke, heart attack, and both kidney and heart failure. It's also the primary risk for the rare but dangerous condition of aortic dissection. That's where you have a severely elevated blood pressure and it causes a tear in your artery and can cause sudden cardiac death. One can have a high blood pressure and not feel anything. And that's one of the biggest reasons I'm talking about these two stroke prevention measures today, cholesterol and blood pressure, because you can feel completely fine and have no idea. And just like cholesterol, 1 in 3 Americans has high blood pressure. Some know about it and some don't. Oh, this picture didn't come through. Sorry about that. So this picture was going to show an ultrasound of a normal heart, and it's a normal sized heart with a normal thickness of the wall. As your blood pressure starts to get higher, your heart starts to work harder over time. And it's like any muscle, it starts to get bigger. It gets bigger in size, it gets thicker in size, and over time it weakens, and you can develop congestive heart failure. So what this picture was supposed to show, that the ultrasound of a normal heart is a normal size and thickness, and over time, as you develop high blood pressure that's uncontrolled, the heart gets bigger and thickens. If anybody's interested in seeing it after, I have it on my phone, so I can show you the pictures. So what matters more, systolic or diastolic blood pressure? So previously, studies had shown that the diastolic blood pressure, the lower number, was more predictive of whether patients were at risk for developing complications. But several studies over the past 30 years have pointed out that the top number, the systolic blood pressure, is a bigger predictor of risk. Systolic blood pressure increases with age, while diastolic pressure tends to decrease once older the age of 55. So sometimes when we talk about blood pressure, we remain sort of fixated on that top number, and that's the main reason why. The difference between the systolic and diastolic blood pressure is called the pulse pressure, and it's also a predictor of increased risk. And other cardiovascular problems can be indicated if somebody has a very wide or high number for their pulse pressure. So how low is too low? I get a lot of calls from patients once they start medications and say, oh no, my blood pressure is too low. The main way to know that your blood pressure is too low is if you feel it, if you feel dizzy or lightheaded, more fatigued. That can be a sign of a low blood pressure. It's almost always due in a normal, healthy person otherwise due to too high of a dose of medication. It can be seen in acute illness and infection and heart failure and in severe dehydration. But in order for your blood pressure to drop due to dehydration, you have to be severely dehydrated, at which point we would start to see abnormalities in the labs. Normal blood pressure can be variable. It depends. It can change from person to person. So what's normal low for somebody may be perfectly fine, and the other person feels great with that blood pressure. Typically, young women and those with weak heart function tend to have lower blood pressures without any side effects. We actually try to keep the blood pressure of patients who have congestive heart failure at a lower level because we don't want that weakened heart to be pumping against a high number. So we usually keep it a little bit on the lower side than for a typical patient because we want that weak heart to sort of have some ease when pumping blood out. So what's the magic number? In 2014, guidelines on hypertension, these are evidence-based guidelines that came out, show that less than 140/90 in diabetics and in those with a history of kidney disease and anyone younger than the age of 60 is ideal, and less than 150/90 in those without the exclusions above and age 60 and older. This is from one guidelines management group, but there are a lot of different other guidelines. Specifically in diabetics and those with kidney function, you often see numbers less than 130/80, and then you may hear less than 140/90 for everyone else. So some dietary modifications. So what can you do? You go into the doctor's office, you've had a normal blood pressure for years, and all of a sudden you get a high reading. And your doctor starts telling you you need to do this, 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 and this. You need to do your diet, watch your diet, you need to start exercising or exercising more. Otherwise, next time if you come in, your blood pressure's high, then they're gonna put you on medication. Because that's really what the diagnosis of hypertension is. It's a blood pressure reading in two separate doctor's office visits that's over the threshold based on what your other medical issues are. So the DASH diet is one of the most famous diets and really known as sort of the best diet for controlling blood pressure. It's rich in fruits, vegetables, grains, including whole grains, low-fat dairy, lean meats, fish and poultry, and nuts. It's low sodium diet. That's a low salt, low sodium diet is really the mainstay part of the diet. And it really helps to lower blood pressure, lower cholesterol, and increase insulin sensitivity, which helps prevent diabetes. So this is a diet that's really recommended, throughout the medical literature for decreasing the risk of heart attack and stroke. And then pills. There's a lot of different pills to treat blood pressure. I'll just go over them briefly. Diuretics are usually the first line treatment. They're basically medications that help reduce your plasma volume, which is the volume in the blood vessels that increase your blood pressure. The side effects may include headaches and dizziness, but usually wear off within 1 to 2 weeks. Hydrochlorothiazide is probably the most common diuretic that we prescribe. Beta blockers are another class of medications commonly prescribed. They're very effective in lowering the blood pressure. They also reduce the heart rate. The names end in LOL. Examples are metoprolol and atenolol. Side effects may include fatigue. And ACE inhibitors, this is a medication that's commonly used in diabetic patients. The names end in pril. So lisinopril, captopril, the main side effect is that it causes a dry cough. It does have a sister or an alternative class of drugs called angiotensin receptor blockers, which don't have that side effects. Those medications are called telmisartan, olmesartan, and valsartan. You may have heard of these or know somebody who's on some of these. Calcium channel blockers are another type of medication. Amlodipine, nifedipine is also one, but amlodipine is commonly used because in low dosages it really has quite a strong effect in lowering blood pressure medication. Possible side effects is lower extremity swelling. And then clonidine is another one that's used sometimes. It's usually added as a third or fourth agent for patients whose blood pressure is not well controlled. You have to be very careful with this medication, especially in patients who have issues with compliance, because if you just forget a pill, you can have what's called rebound hypertension. So you forget to take a pill, next thing you know, your blood pressure is higher than it was even before you started the medication. And so that's one issue we have with clonidine when prescribing it. Each medication may reduce the systolic blood pressure by about 15 points and diastolic blood pressure by about 10. And that's why you see, you may be on, or you may see patients that are on multiple medications because they need more to get to the right level of pressure. So what if there's a difference in readings between the arms? So studies have shown that differences in the readings between arms increases your risk of developing a heart attack and stroke. It's definitely a sign of peripheral arterial disease, meaning plaque buildup in the arteries in the extremities of the body, because you're reducing blood flow due to the plaque buildup or due to the blocked blood flow, and therefore the pressure is lower. The most common cause is a cholesterol blockage or plaque at the origin of the left arm. It's not very common, and it's almost never seen in non-smokers and non-diabetics. And another thing that the difference in the blood pressure readings in two arms can be associated with is what's called aortic dissection, where you actually have a tear in the aorta, and that can be in medical, it usually is a medical emergency in patients who have severely elevated blood pressure. And one of the things we do when we first suspect that in the ER or in the office is take the blood pressure on both arms. So future treatments, high blood pressure despite treatment with 3 or more medications is termed refractory hypertension. Usually in that case, if the patient's younger, we start to look at secondary causes of high blood pressure. Some tumors can secrete hormones that elevate the blood pressure. You can have renal artery stenosis. That means the blood flow to the artery is diminished, and that the blood flow to the kidneys is diminished, and that can cause high blood pressure. But the vast majority of issues is either due to low rates of compliance with medications, people forgetting to take medications or taking them during the wrong time of the day. In those who truly have difficult to control blood pressure, a novel technique called renal denervation, that's basically where they remove some of the input to the kidneys, is now undergoing clinical trials, but it's not available, in the community. So we touched on 2 major risk factors for stroke: cholesterol and high blood pressure. Both of those risk factors are important because they don't really have symptoms. So it's important that when you go to your doctor that you sort of have these addressed. If you go to your doctor's visit on a day that you're also having back pain or they're doing your physical, they may not have time to address these stroke risk factors in detail with you. So the things I would advise you to do is take some time to assess and make sure you know what your personal risk is of developing a stroke. Know your cholesterol numbers and have your blood pressure checked regularly. Know what your numbers mean. Don't just walk out and say, oh, my cholesterol is 120, my doctor said it's fine and I'm good. I don't need to worry about anything. Well, what does that really mean long term? And which direction is that going to go in if we don't do anything about that today and we're 50? Is that going to be 140 when we're 60 and 160 when we're 70? I mean, what is the rate of progression, and what do we need to do now to help keep it under control? If you're diabetic, make sure your diabetes is under control. It's considered a cardiovascular risk equivalent, meaning that having diabetes is just like having had a heart attack or having had a stroke. So it's really important that your diabetes is under control. I already touched on this, keeping it simple, understand what your numbers mean. Utilize your doctor as a partner in reducing your stroke risk. So, as I was saying, go in when there's time available to address. Maybe make a separate appointment just to talk about these risk factors. And be open and honest. A lot of times when you're in the doctor's office, some of the questions can be intimidating. How many times a week did you exercise? And what did you eat for dinner last night? I mean, sometimes, these are all not things we want to, announce loudly, or we're not maybe not so proud of, but be open, because if there are challenges in your diet or in your exercise regimen, your physician can be very helpful in helping guide you and get you onto the right path if they know what some of the barriers and issues are. Modify your diet as needed and really get moving, exercise. Even if you can't do what the recommendations I put up earlier are, don't feel bad. Do what you can. Ramp it up as tolerated. Make exercise a fun and an invigorating experience for you so that you'll be able to maintain it throughout your life. If you drink alcohol, do so in moderation. And I think I already talked about knowing your numbers. And if you're diabetic, follow your doctor's recommendations carefully to control your diabetes. Include exercise in your daily routine. I mean, some of this is kind of redundant, but if you experience any stroke symptoms, call 911 immediately. Every minute matters. This is the address of the office location, and I have cards here if you guys have any questions. I can take them at this time. Go ahead.
You mentioned that amlodipine is calcium channel blocker.
Mm-hmm.
What is the effect of taking amlodipine on the calcium level in blood?
It doesn't have any effect on the calcium level in the blood. It basically is not preventing calcium from being absorbed or ingested by the body. It's just working more at the receptor level. So the arteries, which control the blood pressure values, have receptors on them. When calcium binds to it, it basically vasoconstricts or constricts the arteries. So by the amlodipine blocking it, it disallows that vasoconstriction from happening, and the arteries dilate more and the blood pressure stays lower. But it doesn't have any effect on the actual plasma concentration of calcium in the body. It doesn't have anything to do with bone absorption or osteoporosis. It doesn't affect that. Go ahead.
If you have some plaque already building up in your arteries, you change your lifestyle and eating habits, can any of that be fixed, or you're stuck with that? It just prevents more?
If you have plaque buildup in your arteries, exercising and diet and medications can help reduce the progression of that. Whether it actually deletes the plaque you have, no one's really ever been able to prove it. But going forward, it's supposed to help, reduce it. That's why when we find hemodynamically significant plaque, we find a lot of plaque, we usually just go ahead and treat it by opening it up with a stent if it's the heart, or in the brain. We don't do a lot of lifestyle things to sort of change it, because the idea that it's going to reverse, or that hypothesis, hasn't really panned out.
Okay, but if you have starting a light buildup, if you change these things, you'll prevent it from
getting worse. Yeah, that's the whole idea. Yeah.
Okay.
Go ahead.
Fibrates, and one question. Second question is for home blood pressure monitoring. Is there a difference between a wrist cuff and an arm cuff?
Yeah, so fibrates are a type of medication that primarily reduce triglycerides. They're in a class called phenofibrates. One of the most common ones that's used is called gemfibrozole. Sometimes patients get side effects from the medication, mainly GI disturbances, so it's sometimes difficult to tolerate. It's a little bit of an older medication, and it doesn't reduce triglycerides as much as the statin medications do, and it doesn't have any profound effect on the LDL cholesterol. It can raise the HDL cholesterol a little bit, but it's not that often used these days. And in terms of answering your question, the wrist cuff is not as accurate as the arm cuff. Okay, go ahead.
Is there any lifespan to the collateral arteries that develop?
You mean, what do you mean?
The arteries develop collateral?
If you have a blocked artery, the body's normal response can be to develop collateral circulation, so sprout up new arteries to sort of get around where the blockage may be. Is that what you're talking about?
Well, is there any lifespan to that?
I don't know. Yeah, I don't, no one knows that. I mean, if people have a significant amount of collateral circulation and we find disease, sometimes we leave it alone. But if they're having symptoms, then that means that collateral circulation is not sufficient. And in that case, we usually move forward with treatment. But nobody really knows, if there's a lifespan associated with collateral circulation. Go ahead.
Just a question. Could you talk about salt, sodium, and the effect on both strokes and high blood pressure? And then the second question, as far as aspirin, can anybody use it without any having any problem with, just for just regular, like you take vitamin, you just take
Sure.
aspirin. How often and what dose? I know there's many kinds of aspirins that can be used out there if you recommend.
Okay, so to answer your question about aspirin, it's available over the counter. So yes, anybody can pick it up and start taking it. For stroke prevention and reduction of cardiovascular risk, the recommended dose is 81 milligrams, so a baby aspirin. Even for those patients who've had a stroke or heart attack, the mainstay of sort of long-term treatment is baby aspirin. Very rarely are patients on full dose. The side effects, really are, patients can have aspirin allergies. That's one of the main reasons some patients can't tolerate it. So they can get, hives, angioedema. Some patients have very strong allergies to it. But one of the other things that we look for are, as cardiologists, because we use aspirin so much, is what it's doing to the GI tract. Sometimes aspirin can cause peptic ulcer disease, so ulcers in the stomach. Those can bleed, and that can cause complications for patients who need to be on aspirin if they've had a heart attack and stroke. So no, not everyone can use it. Some people get GI discomfort from it, like they just don't feel well when they take aspirin. In that case, I usually tell them to get the enteric-coated aspirin. So it's an aspirin 81 milligrams, like if you get it at Costco, and then there'll be like an EC on the bottom. That means it's a coated one and it's easier to tolerate. So you can have GI discomfort from the aspirin. It's not necessarily ulcer disease, but it's something that sort of raises our, red flag that it could be. And then especially if someone's complaining of dark stools, then we start wondering if they're bleeding from the aspirin from an ulcer in the gut. So not everyone can tolerate it. Can you take it like a vitamin? It really depends on what other comorbidities you have. I mean, if you've got, diabetes, should you take an aspirin 81 milligrams? Yeah, you should. But, that's a discussion in detail you'd really have to have with your doctor before I would say just go take it like a vitamin. It is a medication, not a vitamin. And then what was your other question? Salt. So the way salt affects the body is that it basically, when it's in your bloodstream, it basically pulls water in. It's like an osmotic effect. So the more volume you have in your arteries, the higher the blood pressure is going to be. So the idea is the less salt you ingest, the less salt you'll have in your plasma volume, or in your plasma, and that will attract less third spacing or volume from coming in, and then that will lead to lower blood pressure. And then the high blood pressure is a risk factor for stroke, so that's why a low salt diet is sometimes recommended for that. Go ahead.
When you say low salt, I'm on amlodipine and losartan, and I couldn't pick it up fast enough. I didn't have a pen with me. One of them is, could you tell me what they are? One's an ACE inhibitor, one's a calcium channel blocker?
You're on, amlodipine is a calcium channel blocker.
Okay, now before we go on, I had a stress test yesterday. Should I have taken that med before the stress test?
It really depends. I usually allow my patients to take the blood pressure medications as long as they don't affect the heart rate. And the amlodipine doesn't, so you could have.
What about the losartan? Does it affect the heart rate?
No. But some stress labs tell people not to take any of their blood pressure medications on the day of the test. So if they told you that, that's okay. There's separate protocols, but you would be fine if you took it.
Losartan, what is it?
It's an angiotensin receptor blocker. So it works.
Angiotensin receptor blocker.
Yeah. It's a pathway in the body, and I'm not going to get into too much physiology here, that affects the blood pressure. And so basically, by blocking a receptor in that pathway, it allows the arteries to dilate more and to filter out more blood and reduce the
Now, can you take these medications like 20 years without problems?
Yeah, I mean, amlodipine is generally a well-tolerated medication. It doesn't have a lot of side effects. The main one, as I mentioned, is the ankle or leg swelling. Usually patients figure that out within the first week or two that they're on it, and there's no question, we just change it. The losartan does have some side effects. It can affect the kidneys over time, and it can affect potassium levels. So if you're on it, your doctor's probably checking those periodically.
Okay, the other thing is you said it's important to take it certain times a day and regularly. Did you say that?
Mm-hmm.
Well, so for these two, what times a day should I take them? And
Both of those are once a day dosing.
I have twice a day, and I have not had a heart attack. Is that unusual?
Wait, what do you mean? You take the medication?
I take the amlodipine and the losartan at the morning meal and the evening meal. Is that unusual for somebody without a heart attack?
No, the thing is that both of them, whenever a medication, whenever we talk about frequency of medication and how often you should take it, it's based on the half-life of the medication, the chemistry of the medication. Amlodipine and losartan both have long half-lives, so you really only need to take it once a day. If your doctor told you to take it twice a day, that you'd have to discuss that with them. I'm not sure why, but there can be some reasons. When I was talking about the timing of the medication, I mean like if a dosing of a medication is twice a day, and say they take it once in the morning and then they're taking it at 4 o'clock. Well, really they should be taking it in the morning, maybe 8 a.m. and 8 p.m. If they're messing that dosing up, that frequency of time, that can affect the medication.
You want a 12-hour window.
It doesn't have to be a 12-hour. I mean, it has to be adjusted to the patient's, schedule too.
So how important is it for a person that's not very habitual? How important is it to really take that at the same time every day?
It's a good idea.
And what happens if you don't? What's the downside?
I mean, I think your blood pressure will fluctuate more.
Which is not good.
Yeah. We could talk more after. I'm happy to talk with you. Go ahead.
Can you take your aspirin and your blood medications at the same time?
Aspirin and blood pressure medications?
Same time?
Absolutely, yes.
Doesn't matter if it's morning or evening?
It doesn't matter. There's really only a few medications. Most of them are antibiotics, and they have to do with absorption that can't be taken in combination with other things. But for cardiovascular, stroke medications, you could take everything. There's not a whole lot that you can't take together that I can think of, any actually. Go ahead.
My husband he had a stroke, and he's in that lucky 10% that had no side effects.
Good.
So now we're working on preventing any future. So he's on Plavix, which is a blood thinner. So should he be taking the baby aspirin too? One doctor said yes, the other one said no.
Well, usually in stroke, if someone's on Plavix, it has to do with either was he taking aspirin when he had the stroke? No. I mean, there's some variability in management. I don't think he needs both. Combination of blood thinners increases your risk of having bleeding complications.
Right.
So I don't know the anatomy and all the details of it, but if you're on Plavix and you're doing well, you're probably okay. Usually the combination of medications is if somebody's already on something and they have a stroke while they're on it, that would suggest that they need more. If that's not you, then I wouldn't say you need 2 medications at this point. Okay,
He
but
takes a low dose of Lipitor. Is that a statin?
that's a statin.
That was for your blood pressure. I don't know what it's called. It's for blood pressure.
Yeah,
Blood pressure
Lipitor's for
really
the.
isn't that bad. We'll monitor it more though. But I have a machine because I have high blood pressure.
Okay.
So I can monitor him more.
Yeah, but Lipitor is for cholesterol.
He really has excellent cholesterol.
Well, these days we don't.
Probably genetics. It probably didn't cause the stroke.
But maybe because there's so many different reasons why. And these days we don't always treat cholesterol based on the numbers. So for instance, we have time, right? What time are we going till? We have time. Okay. In 2013, a new risk score came out that basically assesses what somebody's cardiovascular risk is. This has to do more with heart attack than with stroke, but I think we can sort of get some understanding of what the idea behind it is. So it takes into account your age, your sex, your race, your blood pressure, your cholesterol numbers, whether you're a smoker, and it calculates what your risk of having a heart attack in the next 10 years is. The American Heart Association really, suggests treating cholesterol, for cardiovascular risk, meaning not so much to play a numbers game anymore, to say, oh, you have to be less than this and you have to be less than this, but to say if your risk of having a heart attack is over a certain percentage, then a statin is recommended. Stroke doesn't have the same type of risk score calculator, but we sort of apply it in saying, well, if a cholesterol is borderline and a patient's high risk for stroke, they might as well be on it. For someone like your husband, it's not primary prevention anymore. He's already had the stroke, so it's secondary prevention. So we know there's some issue, whether it's the numbers or whatever it is. He had a stroke, and that's probably the reason they have him on the cholesterol medication. Go ahead.
What time of day do you take niacin for cholesterol?
Whichever works for you, because the side effects can be so dramatic. A lot of patients like taking it at night because if they get the flushing, they don't want to be out and about, doing things or at work. If you're not having side effects, it's fine, but if you are, I would say take it at bedtime.
How do you know when it's time to get off blood pressure medication? I went off once cold turkey. The doctor said it was okay to go cold turkey, and it just wasn't the right thing to do. I had all kinds of symptoms and everything. I just went right back on.
Yeah, it really depends.
Doctors too.
It really depends. I mean, patients, I'm a patient too. I don't like to be on a ton of medications. And if you've been on something for years, the question's going to come along. Do I really need this anymore? I really tried to put it in some context of what the patient's clinical risk is. So if someone has blood pressure that's pretty well controlled and they don't really have any other medical problems and they say, I want to try coming off of it, I'll say, fine, come off of it for 2 weeks, record your blood pressure, and come back and see me. If you feel awful, restart it. I mean, that's the only way to know. There's no magic way to find out how you're going to do without it besides stopping it. If someone's had a heart attack and stroke and other, kidney disease, and they have high blood pressure and it's well controlled and they want to come off of it, I usually steer them in the other direction and say, hey, you've already had consequences of, the high blood pressure, presumably, and so I don't think that's such a good idea. If they really insist, then yeah, it's the same thing. All right, stop and see what your numbers do and then come back and see me, I mean, it's really the patient's choice. When you say cold turkey, it's, it seems harsh, but it really depends. Were you on 3 medications and you just stopped all 3 in one day? I mean, if you were on one low to medium dose medication and you stopped it, that's reasonable. And, when you didn't feel well, you kind of prove to yourself that you do need it, right? And that's sometimes what patients need, to sort of be compliant with the regimen.
But you go off slowly, right? I mean, real gradually, or?
There's no real way of tapering these types of things. I mean, some of the pills you can't even split. Some of them are capsules. So if you're on, something like amlodipine 5 milligrams a day for your blood pressure and you want to stop it, I'm not going to tell you to taper it. You just stop it and see how you do. I mean, if you wanted to take it every other day and prolong it, you could, but usually if you stop your medication, you'll know whether it's working or not within a week, whether how you feel and what your blood pressure's doing. Yeah. Go ahead.
What's the incidence of a second stroke if you've had one already?
Well, it just increases your risk of having, what's the incidence or what's it?
I mean, what is the chance of having a second stroke if you've had one already?
I don't think I can really define that. I don't know if anybody really knows that number, just like what's your chance of having a heart attack if you've already had one. Obviously, it's increased. But, that's why we work so hard on prevention, and why after a heart attack or stroke, people are on so many medications, come for a stress test, get ultrasounds done, get ultrasounds of their neck, and so and see specialists is really to prevent that. But I don't think that there's a number I can give you for that. You had a question? Go ahead. Yeah.
Is Plavix something that's taken long term or is that short term?
Plavix can be taken short term or long term. It really depends on what the indication is. Yeah.
You may have covered this, but what is the window of time? Like, God forbid, I know somebody who has all the symptoms of a stroke. You call 911, but how long do you really have to get the right kind of medical treatment before you're in trouble?
Well, it really depends. If you're talking about TPA, I think it's something like 6 to 8 hours. By the time the onset.
Did you say CPA? What'd you say?
TPA, the clot buster.
Oh, the clot.
Yeah, you need to be,
6 to 8 hours.
mhm.
Well, didn't you just say you should call 911 and get right over there? So that
Well,
you
when
get
you-
treatment really fast?
The faster you get treated, if you have symptoms of a heart attack or stroke, you shouldn't wait, right? The longer you wait, the more damage is being done because blood is effectively not getting into your organ system, your brain. So you don't wait, but if there is a delay in getting to the ER for whatever reason, after that window, they're unable to provide, to offer as many
I
treatments.
actually know someone, a very wonderful person that happened to. She just wouldn't go to the doctor.
Mm-hmm.
And she is in a wheelchair and she cannot talk intelligibly and she cannot play the piano like she did for many years, and it's very sad if she's
Yeah.
only gone in.
Any other questions? Go ahead.
I wonder if you have a parent who's had a number of TIAs and a stroke, what is the genetic outcome of that?
Well, I don't think that in terms of treatment, like, you know, would if you went to see a neurologist or a cardiologist and you said this, would they treat you any differently? No. They would just say, what are your risk factors? And then sort of optimize them for you. If you are really concerned, you can start taking a baby aspirin unless you had some contraindication to it. But besides that, you know, there's not really any way that we would treat you differently. Just like we don't really treat patients that have, you know, family history of heart attack. When they come in and they say that, clinically we may be like thinking, you know, that sort of raises some red flags for us, and we may be more aggressive about testing and things like that. But in terms of what we're going to do, probably nothing. Yeah. And what your risk will be, we don't know, because you're a combination of two, you know, so it's hard to, you know, and sometimes it skips people, and lifestyles are very different. You know, what maybe your parent did, you know, is very different than what you do, which would place you in a completely different risk category for a stroke. Yeah. Is there any other questions? Because then I can just address some of hers. Go ahead.
Okay, you mentioned several kinds of rehabilitation after a stroke. Does Medicare pay for rehabilitation?
It depends. I mean,
How would you, what do you know about that?
I don't know much about it besides my experience in the hospital. Everybody has different Medicare benefits, and rehab facilities in general are not covered for an extended period of time unless you go from inside the hospital to directly to a rehab facility. Then I think it's covered for 30 days. That's what I've been told. And then beyond that has to do with your benefits. Yeah. But don't quote me on that. I'm not a case manager or an insurance expert.
So I know who to talk to, a case manager, they would know.
Case manager would know, but they need to know specifically what your benefits are.
Yeah.
Yeah. Go ahead.
What's the difference between atenolol and propranolol, and is it easy to transition? Just get off the atenolol and just go right down to the other one, propranolol?
Well, propranolol isn't really used that much for, are you talking about for blood pressure management? It's not used that much for blood pressure management. It's an alpha and beta blocker, so it works on two different receptors. And it's not as effective as lowering the blood pressure as atenolol is. Yeah. So if you're on I don't use it to treat blood pressure. Yeah.
If your cholesterol is basically the normal range.
If you're what?
Cholesterol.
Cholesterol.
That's the normal range.
Mm-hmm.
Is it still advisable to continue on statins medication?
If they came to a normal level on a statin, then yeah. I mean, because you got to that level because you were taking the medication, so presumably if you would stop it, you would go back up. It's hard to say, you know, because, you know, patients also change their lifestyle when they find out they have cholesterol and go on statins. So, you know, you can have some maybe reduction in the dose. But generally speaking, as you get older, the cholesterol numbers tend to go up, not down. So, you know, if you started it a few years ago and you came off of it, I don't know what your numbers would be.
I heard a lot about side effects of statin on brain, like dementia.
Dementia.
Alzheimer's.
It's really anecdotal, you know, suggestions. It's nothing that's been proven in a randomized controlled trial, you know. So as a I know there's a lot of patients who have concerns about it, and everyone has the right to make the best decision for themselves. But as a cardiologist, the data I have is that it's one of the only medications on the market that lowers the risk of heart attack, stroke, and death. And that's what I'm treating, and I don't see the long-term trials showing that it causes Alzheimer's disease. Those are obviously going to need to be done and addressed, but at the current time, there's no indication for someone not to start it because of that.
Is the lowest level of atorvastatin 10 milligrams, or is it
You can cut it to 5. Yeah, you can cut it to 5, but the lowest pill, I believe, is 10. You know, in terms of statins, there's low intensity, high intensity, moderate intensity statins. The Lipitor sort of falls into the moderate to high intensity. There are lower intensity ones like pravastatin, lovastatin, and then the highest intensity one is Crestor. So you're kind of here if you're on atorvastatin or Lipitor. So based on your dose, you know, and how much you're on and which intensity you are, that's the type of effect you're going to get. So, you know, if you wanted to lower it, you could, but you'd have to just. I usually tell patients, if you're going to lower or change your cholesterol medication, give it 3 months and then have your cholesterol checked again. You want to give it enough time to have the effect on the numbers so that you can kind of see where you went with it, you know. And everyone's going to respond differently. Some people are going to come down and be completely fine, and other people's going to shoot through the roof. It's hard to predict. Go ahead.
Is there a difference between Lipitor and, in your opinion, and a generic
statin?
I don't think so. You know, I have patients, a lot of them from Europe and Australia sometimes, who get a lot of the trade medications, and they seem to always want those. You know, they have to pay out of pocket dramatically for them. I have never seen a major difference in the numbers. Mainly they want them because they seem to think they're going to have less side effects. Again, I can't say that for me personally as a clinician that I've seen that pan out. So no, I don't think that there's a difference. Go ahead.
What do you see as the difference in effectiveness between Lipitor and Livalo? If there have been side effects from the statin?
Are you talking about pitavastatin?
Atorvastatin, yeah.
And when the second one you said?
Livalo?
I think that's pitavastatin. I think you're talking about a trade name. I'm not exactly sure which one that is.
The brand name, I don't know.
Yeah, the generic name. I'll talk to you after. I think I know what you're talking about, but it's not covered by a lot of insurances, so I haven't used it a lot. So I think it's pitavastatin. That's considered a low-intensity statin, pitavastatin. The Lipitor would be much higher than that in terms of intensity, if that's what we're talking about, the same thing. And one of the reasons pitavastatin has been sort of marketed, although it's still very expensive and not accessible to a lot of patients, is that it doesn't have the side effect of the myalgias, the muscle aches and pains that a lot of the statins have. Yeah.
Is it as effective in controlling?
No, it's a low intensity. So no, it won't have as a dramatic effect on the numbers. Go ahead.
I find you to be outstanding. Thank you for coming.
Oh, thank you.
How long have you been in practice?
I have been in practice since 2013, so what, 4 years?
Well, it's really wonderful to have somebody so informed and on top of everything. I really appreciate it.
Oh, thank you very much. Thank you for having me here. I appreciate it.